Thank you very much. That's always refreshing to stop and make sure that you're taking care of yourselves, because, again, we need you healthy to take care of us and keep us healthy. And on that theme of MS treatments and management in improving the quality of life, Dr. Orla Gray, who is a consulting neurologist at Ulster Hospital, the Southeastern Health and Social Care Trust in Belfast, is here to talk with us about treatments and managing to help MS quality of life.
Thank you very much. Thank you for inviting me to come and talk today, and I'm really pleased you came to hear that last talk. I think I'm really relaxed and in a calm and happy place. So I hope we're not all too falling asleep now in the audience. We'll have to get back into this again.
Recording the session, so you can use the program. Get the notes here.
Okay, and then you'll have to do that. Okay, and then just this one. Okay. So before I start, it's always good practice for me to show you my conflicts of interest. I don't think anything are relevant today. I do a lot of work for an observational database and registry in MS called MS Base, and I'm the UK representative for them. They themselves are an independent not-for-profit organisation, so they run as a charity. And just to let you know, my links with them, I'm on their scientific leadership group and I'm a board member, but I'm not a paid member of MS Base. So every time I come to talk about MS, and in particular when the topic is about treatments and management, actually when it comes to afterwards, the questions usually go back to parts of the beginning. What actually is MS? Who gets it? Who's at risk of it? What's a relapse? These sort of questions. So I thought what we could do, and I'm hoping just if you can be as interactive as you would like to be, just stop me and ask questions at any point in time, and we'll just see how we get on. So everyone knows that MS is a neurological condition, and we all know the term inflammatory demyelination. But it's really important to know that MS is a condition that affects the central nervous system. So we've got two parts of our nervous system. We've got the central nervous system and the peripheral nervous system. So the central nervous system is our brain, the brainstem, which is the little bit that sits under the brain, the entire spinal cord, and actually the optic nerves are part of the central nervous system. It's the only nerve that is part, and that's because from an anatomical point of view, before birth, the optic nerves and eyes are actually part of the brain and come out. So that's why the optic nerves can get affected in MS, and that's why, and they're the only peripheral nerve as such to be affected, but it's because they're not really a peripheral nerve. So when the spinal cord goes down, there are nerves that come out at each level of the spinal cord, and they're the peripheral nerves, and they are not affected. So we know MS is a condition which causes patch of inflammation in the brain, the brainstem, the spinal cord, or the optic nerves. Now, where does the term demyelination come from? Well, it comes from the actual nerves in the axons in the brain or spinal cord themselves. And what happens, if you can see in this diagram, I can point it. Do I have a pointer there? No. So the top left, you get a patch of inflammation, which affects the myelin sheath of this axon. Now, the myelin sheath of the axon is a bit like the plastic wire on our cables. It allows the conduction through the metal parts to run really, really smoothly. And it's the same with these axons. So when you get a patch of inflammation and the myelin strips off, this axon can't work as efficiently as it used to. Some people's will be a little bit irritated or damaged. Sometimes that will come back, and sometimes there will be a long-lasting effect. And that's why with an episode, like a relapse, some people will make a full recovery, some people will make a bit of recovery, and some people don't make any recovery after an episode. So, to diagnose MS, a person who will initially have a single episode of inflammation of the nervous system, and the first episode is either called a clinically isolated syndrome. Has anyone in the audience heard of that term? Something that you would have heard of? Or a first demyelinating event. And essentially, those terms mean the same thing. Where the inflammation is, we sometimes give other names. So optic neuritis. Itis is our term for inflammation. So when people have appendicitis, they have inflammation of their appendix. So an optic neuritis is inflammation in the optic nerve. A transverse myelitis is the name given to a patch of inflammation in the spinal cord. So myel being spinal cord, myelitis, inflammation. And you can have inflammation in the brain or the brainstem as well. So when someone has a first episode of demyelination, a clinically isolated syndrome, they will be at risk of, or may in fact at that point in time, have multiple sclerosis. The key to the diagnosis is evidence of what's called separation in space and time. So separation in space is two different parts of the nervous system. So someone who's had an optic neuritis and a transverse myelitis at the same time, it's two separate parts of the nervous system. That's evidence of separation in space. Separation in time is two different time points. So one episode in April of this year, another episode in August of this year is evidence of separation in time. And it's really important, and in all the criteria over the years, that there's no other good explanation for their symptoms. So when someone goes to see a neurologist, as well as listening and hearing for the typical history of an episode that sounds like an MS episode, it's also really important that we're thinking of other things and saying, well, it doesn't sound like that. Our newer criteria, as time has gone on, our newest criteria is the McDonald 2010 criteria, and look, most centres would be using with this type of criteria these days. So just, I've got a list of some of the MS things that can look a bit like MS. And some of these things in this list actually usually are quite obvious that it's not MS when someone comes to see me. People can come because of the look of their MRI scan. So an MRI scan with white matter lesions that are non-specific in nature, which means they don't follow the typical pattern seen in MS. The other causes of white matter lesions, the commonest cause is lack of blood supply or ischemia. So these vascular causes at the top are usually the differentials for people who come within an abnormal MRI scan rather than the clinical picture or the episodes that they've described being similar. So when we look at the diagnostic criteria that we use nowadays, so we're looking for evidence of both separation in space, which is two different parts of the nervous system, and separation in time, two different time points. Nowadays we can use MRI as part of the criteria to look for evidence of separation in space and separation in time. So nowadays when someone has their first episode, which is the clinically isolated syndrome, their MRI can be used and if it follows a specific pattern, it will show evidence of separation in space. And a single MRI can also show evidence of separation in time. And it does that with little, when contrast is given, if there are enhancing lesions, which we know enhancing lesions mean new lesions, and they're usually maximal 4 to 6 weeks old if they still enhance, and non-enhancing lesions in the same person. So, the commonest first presentations and then presentations in relapse would be the optic neuritis. And an optic neuritis is the first presentation in about 40% of people who go on to develop multiple sclerosis, spinal cord, which is transverse myelitis. A brainstem syndrome would be called a brainstem inflammatory syndrome, or a cerebral event. So I'm going to show just an example here. This is someone who's presenting with an optic neuritis. Now, the classical features of an optic neuritis would be a progressive onset, which means that it starts slowly and builds up gradually, and that would be typical for all type of MS symptoms. Of blurred vision in usually one, though it can happen in both eyes at the same time. The key to the optic neuritis with MS is that there's usually pain on eye movement as well. Now, not just a vague pain around the eye, but a specific pain on movement of the eye, because as the eye is moving, the optic nerve is being stretched and the patch of inflammation is being irritated. So if I have someone who comes to see me and they've had an optic neuritis, I'd say about 10 years ago, when people had an optic neuritis, they really weren't aware that there was a risk of MS with it. Nowadays, everyone, you only have to put the term optic neuritis into Google, and MS is the first thing that comes up. So it's important that people are aware that if they have an optic neuritis, there is a risk of MS. What the MRI can do at this point is actually classify and characterise that risk. So I know that the risk, if someone has an optic neuritis, the overall risk of having MS in about 15 years is 50%. If their MRI is completely normal, their risk is much lower than that. It sits about 25%. But if they have lots of lesions on their MRI, the risk sits at about 80%. And that's really important, because there's a huge difference in those risks. And we're able to have that conversation with someone, and so the person knows their individual risk and can re-present early if they have new symptoms, and that's really important. So, just to show you the MRI, there's an MRI of the brain at the top that shows the sort of classical lesions that you can see in MS, and the two, I don't know whether you can see, in the spinal cord. So in the spinal cord, the lesions are normally quite small. They certainly shouldn't be bigger than 3 vertebrae. And that's when you think of other inflammatory conditions of the spinal cord. And they're normally sort of that oval shape that you can see there. And they're normally a little bit asymmetrical. So if you have this ones at the other side that are looking through them, you can see that the little inflammatory lesions usually sit to one side rather than sitting right in the middle. And on the brain scan, what you can see at the top is you can see that there's the periventricular lesions, particularly the ones in the corpus callosum, which is the bit that sits over the top of the ventricle, and that's a classical case for someone to get lesions. So this MRI is showing evidence of separation in time, because in the top you can see that there's enhancing lesions and non-enhancing lesions in the same MRI. If there's not evidence of separation in time at that point in time, you can repeat the images any time point down the line. After a first event, I would normally say about 6 months. And at that point in time, if there's even a single new lesion, that would be enough then to say that is evidence of separation in time. So the person who's presented with their optic neuritis will get over that episode. They'll be aware what their individual risk of MS is, or if their MRI has enough features, they may have the diagnosis of MS at that point in time. For some people, we will need to wait, if there's no new MRI activity, for them to have a new clinical episode before they get a definitive diagnosis. And I think it's really important that people understand that that's why there's difference when somebody goes to see a neurologist, because one person could come and see me and I'll say to them on the day, because I have one MRI and their story and their examination, this is MS. In another person, I might say I need to do more tests, and I might want to do a lumbar puncture, looking for inflammation in the fluid, the lumbar puncture fluid. That inflammation we look for is called oligoclonal bands. And that's an important thing to look for, because the oligoclonal band is a big protein. It can't get there from anywhere else. If it's there, it was made in the spine, somewhere in the brain or spinal cord. So again, it's evidence of inflammation in the brain and spine, but not everyone. Okay, not everyone who is diagnosed with MS these days actually needs one. And in fact, as the criteria have used MRI more often, less and less people actually have needed one. Is that better? Okay, just to move on to the different types of MS. If looking at this diagram, if you read about this, if you read a textbook or you look online, you would think this part is easy. But actually, in real life, it's not always as simple as it looks. I know that 85% of people will start with relapsing remitting MS, and 15% of people presented with primary progressive MS. But actually, it can be very, very difficult at a single point in time to be 100% sure what type of MS someone has. It's very difficult when someone has relapsing remitting MS and is entering into the secondary progressive phase to make a definitive call on one occasion. So, relapsing remitting MS, more commonly seen in the younger age group. So 85% of people will present with this type of MS, and this is the type that is more common in the 20 to 40 year age group. This is the type that has a much higher female to male ratio. It's at least 3 to 1. Well, again, when you read about it and you read, it talks about episodes being events that last for a certain length of time and completely disappear, with being well and suggesting completely well in between episodes. And of course, it's not that simple. Some people don't make a full recovery from a relapse, and that's one of the reasons why it's really important to treat relapses aggressively. Some people will make a full recovery, but their symptoms will come back when they're unwell in other ways, so when they're overly tired, overly stressed, if they have an infection. And that can be difficult to work out. That's called a pseudo-relapse, and it can be difficult for someone to actually work out themselves, and sometimes difficult for me too, to work out which episodes are relapses and which episodes are pseudo-relapses. So as time goes on, there's a group of people who will enter the secondary progressive phase, and it's really difficult to put a point in time on that as it happens. Again, if you read about it, it sounds perfectly easy, but normally what happens is that someone's mobility can slowly start to progress, but at the same time, they can still have relapses. Now, as time goes on, the relapses can become less and less, but they're still there. And as we've got good treatments, disease-modifying treatments for relapses, this group of people who are entering secondary progressive MS but are still having relapses are treated just the same as people with relapsing remitting MS, because these relapses are worth trying to prevent. So, primary progressive MS, it tends to occur more in older people, so it's more commonly seen in the 40s and 50s than younger. It's equally as common in males and females. And normally the person gives a progressive history, and it usually affects their mobility in some way first. Can be difficult at the start because there can be fluctuations, and certainly people with progressive MS can still have episodes that are suggestive of relapses as well and can respond to treatment of that, so it can be difficult as well. Who gets it? So, talked a bit about this. It's really, really common. In Northern Ireland, we think we have about 4,500 cases. I think the estimation in Southern Ireland is about 8,000, but I think we're probably underestimating it. It is a condition that affects young people. We do have people younger than 20. Not a lot, but we have a handful, certainly, of people. Our youngest person in Belfast was 12 when they were diagnosed. So it is affecting a younger population. It's more common in Caucasians and more common in females. And when we look at around the world, there is a huge difference in the prevalence rates in different countries. You can see we're all sitting in the red group, which is the highest group. And there has been a recognised latitudinal variation, though it's not consistent across countries. And that has even been shown in Ireland between the studies of Donegal and Wexford, for example. And it's definitely seen Northern Ireland and Scotland have a higher rate of MS than Wales and England. So there is a definite variation shown there. But we're probably not picking up everyone, and it probably is an underestimation. I think the last time, 2004 was the last time we did a prevalence study in Northern Ireland, and I think it probably was about the same as in the south of Ireland as well. It was the last time prevalence was looked at. So female to male ratio is increasing over the years, and we've seen this consistently. We don't know why. There's lots of theories, but actually we don't know. I think I'm asked this quite a lot in clinic. What causes MS? I can never answer it in 30 seconds. That's for sure. It certainly is complicated. There's definitely genetic factors. There's definitely factors that predispose, and those genetic factors. There's lots of genes that have a little effect, and it's having so many of those that will place you at risk. And there are genetic factors that can predict outcome, but they're not strong enough for us to be able to use that on one person. There's definitely environmental factors, and there's lots of hypotheses regarding this. Is there a vitamin D element to this? Certainly from the latitudinal studies, you would think so. But there's a lot of things here that we don't actually have the answers to. We know that there is a genetic aspect from looking at the different family studies, and you can see that the risk in identical twins is much higher, and they've got they've got identical genetic material or almost identical material, and it's a much higher risk than other family members, as you can see. So we do see families where there's more than you would expect to find by chance in the same family. So there is a higher risk of developing MS even with a single family member. Is there more MS now? Every time we do a prevalence study in Northern Ireland, our prevalence has increased, and we think there is genuinely more MS, but we're picking up more as well. There's certainly more neurologists. There's easier access to MRI scans. The MRI scanner arrived for the first time in Northern Ireland in 1993. So before that, people didn't get them, or we sent a few people over to London to get an MRI scan. So we're certainly performing more investigations. And the diagnostic criteria have changed, so the use of MRI is part of the diagnostic criteria, and the use of being able to diagnose people earlier, which is, as you'll see, is very, very useful. Has meant that we're diagnosing more people, and people are presenting earlier. It wasn't uncommon when I started in neurology, which was about 17 or 18 years ago now, that some people with MS presented when they entered a secondary progressive phase, and you got a history of episodes, 5, 10, 15, maybe 20 years ago, but they didn't actually come or do anything about it. And I think that would be unusual nowadays. I think people are aware that if you have neurological symptoms, you should really go and get them checked out. And I think with the use of MRI as well, we're finding we've got this new concept of a radiologically isolated syndrome. And so when I see someone who comes to clinic with an MRI with white matter lesions on it, they could either be ischemic lesions, so little bits that have lost their blood supply, and you look at the risk factors for heart attacks and strokes. And someone who has a lot of those risk factors, they're more likely to be linked with that. Sometimes the MRI comes back and looks like the classical picture that I would see in someone with multiple sclerosis, but when I take the story, there has never been a single episode of anything that sounded like an inflammatory episode, and their examination is completely normal. So that person has what's called a radiologically isolated syndrome, and I would keep an eye on those people and follow them up. But actually, how we manage that group, we really don't know at the moment, so this is an area where we need to find out more. I think it's really important that everyone is, as much as we can, aware of what a relapse is. Because I meet people with MS all the time who'll say to me, I don't really know what a relapse is. And sometimes that's a really, really good thing. That's because they haven't had a relapse in many years. And I'm able to say to them, well, that's great that you know that you don't know what, because you really haven't had anything since your first or your second episode. And sometimes because someone doesn't understand the difference between a relapse and their other everyday symptoms, or a pseudo-relapse, and it's really important to be able to try and work that out. Because relapse activity is linked with new lesions on an MRI, and relapse activity is completely treatable. So the definition of a relapse hasn't changed since 1967, which was the first time we got a true definition. And in that time, the definition of MS has changed on multiple occasions. So actually, it's not perfect, but it really is I think it got it quite right. So it's a focal deficit, which means it's something neurological. So focal deficit to me means weakness or numbness or balance problems or blurred vision or double vision. But it's something new, and it lasts more than 24 hours, and it has come on at least 30 days after something else. So to classify what's a new relapse and what's part of a longer relapse. So it's after 30 days when someone was well. And ideally, a relapse would be confirmed by a clinical examination. Though sometimes I bring people up to clinic to see them, and I'll be able to say, yes, this is new, and you're definitely worse than the last time I assessed you. Sometimes the story is enough for me to go, this is definitely a relapse. But it's really important to think of pseudo-relapse, because in my experience, people presenting with new symptoms, it's at least as common to be presenting with a pseudo-relapse. So pseudo-relapses are not related to new disease activity. The symptom is normally something that the person has had before in a relapse. So it could be someone who's had an optic neuritis before, and they've got blurred vision in that eye again. Now that in itself doesn't mean it's not a relapse, because you can have a relapse in the same area, so you do need to be careful, but it's usually a symptom that you've had before. It normally comes on quite quickly, so quicker than I would expect a relapse to happen. So a relapse normally starts slowly and builds itself up. The average relapse takes 7 to 10 days to get to its worst, stays there for 7 to 10 days, and then starts to improve. But there's a huge spectrum in there. And a pseudo-relapse can settle quite quickly when we work out what the cause of it is and treat the cause. And the commonest cause would be an infection or a temperature rise, which is why every time someone rings and speaks to one of the MS nurses with a new symptom, the first thing they will say is, when you get your urine checked, quite common to have a urinary tract infection and not be aware of it. But it can be any other cause, so a vaccination, physical stress such as surgery, or an emotional stress that can precipitate a pseudo-relapse. And the treatment of the pseudo-relapse is treating the underlying cause. So steroids are not going to help the pseudo-relapse. Treatment of the pseudo-relapse is the underlying cause. And you just need to be careful, because sometimes people can have a symptom with an infection. We treat the infection and say, oh, that most likely was a pseudo-relapse. But actually, after the infection has gone, they still have symptoms. And in that case, then I would think, well, that infection has actually caused a relapse. So it can be difficult to tell. Okay. So the natural history of relapses is that over time they get a bit less, and certainly, but there's not a clear point where you can go, well, that's when relapsing remitting MS has stopped, and this is when the progressive phase has begun. Early relapses are really important. So there's association between the number of relapses, more relapses in the first 2 years, and some disability. The duration of time between your first 2 relapses is predictive of disability in the long term. And people who have had their first episode and made a good recovery, there's a slower rate of disability progression. So the early relapses can be predictive of things in the future. The later relapses, there isn't as much evidence of this, that the effects aren't quite as strong as time goes on. Okay, so I'm going to talk about treatments. There's lots of different types of treatments in MS. From relapse activity point of view, there's actual treatment when someone gets a relapse, and then there's the treatments that we use to prevent or reduce the number of relapses someone has. Treatments, we'd like to have more treatments to delay progression of MS, and it's really, really important to look at symptom management in people with all types of MS. So newly diagnosed people with relapsing remitting MS who look perfectly well and haven't had relapses can still have disabling ongoing symptoms and can benefit from management of those. When we think of treatment for relapses, my first so treatments that we use are corticosteroids or steroids. You can give them by mouth or intravenously, so into the veins by a drip. What they do when someone has a relapse is that they can shorten the actual length of the relapse itself. If they're given early, and by early I mean as the relapse is still getting to its peak, they can stop a relapse getting to its peak. But actually, when you look further down the line, there's no major difference 6 or 9 months or a year down the line where whether people had steroids for their relapse or not. They do have significant side effects, but some of the side effects, obviously, from steroids, things like osteoporosis and diabetes, are not as worrying when you're giving short courses of them. More commoner side effects with the short courses would be effects on sleep and mood. Sometimes people feel great on steroids, but that greatness is a euphoria, it's a side effect, and the person who feels great on steroids normally feels the dip coming off them. And that dip is going back to their baseline. It's not going lower, but it can feel like a real downer. So we do need to be careful. Relapses, the evidence for them would be for weakness of arms or legs, balance problems, and the evidence actually is pretty poor for visual problems. So there's always a question over whether we give steroids orally or intravenously. And actually, in Northern Ireland, we follow the NICE guidance for the management of MS and for the NICE guidance for all the disease-modifying treatments. And NICE guidance does suggest using oral methylprednisolone. And there's evidence to suggest that there's no significant difference between giving it orally and giving intravenously. Oral methylprednisolone, every time I do prescribe it, or very, very often the dose is questioned. It is a 500 milligram dose. It's the same dose orally. It's oral methylprednisolone, 500 milligrams daily for 5 days. And I would normally prescribe a proton pump inhibitor because it can cause gastric irritation. But actually, no more other common, the side effects aren't any more common with oral than they are with the IV. And obviously, people can start them straight away if they're having a relapse. I'm not sure what it's like in different parts of the country, but certainly in Northern Ireland, if you wanted to bring someone up to a hospital day unit to get steroids, there could be a bit of delay before you could do that. So it's been very useful. I find it practically very useful that we can use oral methylprednisolone as an alternative to the intravenous methylprednisolone. So we have lots of medications nowadays to prevent or reduce the number of relapses, and this has the landscape here has changed dramatically already, like in my lifetime, but even in this past 5 years. The whole idea is, and we want to start people as early as possible, the people who are going to need disease-modifying treatments. And the person needs, like, these treatments are not a cure, but they do a good job. They do significantly reduce relapses. Relapses are worth having less of. Relapses can cause disability in themselves, and so these are very useful treatments. And there's evidence that actually starting them after the first episode, a clinically isolated syndrome, even if a person doesn't meet the criteria for MS, starting them at that stage can actually prolong the time before they have new disease activity, either on MRI or clinically, so it prolongs the time before someone gets a diagnosis of MS. So I'm not sure if it would be used in that context in the south of Ireland, but certainly in Northern Ireland we would use them in that context as well. So, lots of treatments available. Now, on this side, I've put the injectables, and the Clozumab is a new drug, and it has got nice approval. We have not got people started on it in Northern Ireland as yet, but I added it recently onto this slide. So when I'm meeting someone with MS and going through the different treatment options, I will talk about them in their broad groups as the injectables, so the beta interferons and glatiramer acetate, and I'll talk about them in that group. And they're the ones we've had, as a group, we've had for many years, and we've lots of information on them. The newer ones, we've got the oral medications, and there's 3 tablets that can be used in MS now, and then there's the infusions. Midazolam wouldn't be used as much anymore. Really would be natalizumab or alemtuzumab. Now, in Northern Ireland, we have very clear guidance. We have the NICE guidance, National Institute of Clinical Excellence, and that they were really set up as a guidance for England and Wales, though we have adopted their guidance, and I do find them very useful. And we have the Association of British Neurologists have got together as a guidance, and they've tried to put the NICE guidance into context together. And these can be very, very useful. I do find it useful that there are clinical guidance. I know that wouldn't be as it would be sort of slightly different in the south of Ireland, but I do find it very useful. So I'm just showing you the ABN guidance, and I've just put a question mark beside Clozumab because I think it would be over there, but it's not in the guidance because it's come out since. We have separated them into category 1 and category 2 drugs. Now, avoiding the terms first line and second line, because the decision on whether to start a category 1 or category 2 drug at any point in time, including as a first drug, is a decision to be made on clinical grounds. So I don't use the term really first line and second line. So the category 1 drugs, beta interferons, glatiramer acetate, teriflunomide and dimethyl fumarate are all there. Well, with fingolimod, there's a slight exception in Northern Ireland with it. These would all be category 1 drugs. Fingolimod, our guidance would say that we can use it in someone who's been on a previous disease-modifying treatment and hasn't done well in that treatment, so we don't tend to use it as a first-line treatment, but we certainly would use the other ones. And as a group, we would consider active relapsing remitting MS someone who's had more than 2 clinical relapses over a 2-year period. We can use them, or we would consider them in someone who's had 1 new relapse and new MRI activity, or in the clinically isolated syndrome at the time if they present within 1 year of their episode. And then the category 2 drugs are for people who would have more active disease than that. And we have quite clear definitions in the natalizumab group for people who have had 2 disabling relapses in a 1-year period and more MRI activity. And we would use that criteria for natalizumab. For alemtuzumab, we would use quite similar criteria. We would say 2 disabling relapses in a 1-year period. We may not necessarily need the new MRI activity. So the decision on the treatment is obviously the patient's decision, not mine, but I'll sit down and I'll go through all the treatment options with them and let them decide. I'm quite often asked if it was you, what treatment would you? And is anyone else in that room, anyone here, asked that with regards to treatments? Yeah, no, not really. We've got a no or a yes? Yes. It's a really well. Obviously, as a doctor, we're not meant to answer that if there is no objective reason to suggest one treatment over another. So I go through all the treatments. If someone's got more active disease, I will say, listen, you've got more relapses than the average person, and your MRI, you've got more activity. I think we need to go at this level of drug. And if someone has not got more active disease, I say, listen, these, it's really good that we have these other drugs there if we need them for you. But this is where we can start, and we can see how you get on with those drugs. But it's a very difficult question. I always explain, because obviously when it comes to the category 2 drugs, I'm explaining usually 2 drugs. I'm explaining natalizumab and I'm explaining alemtuzumab. And I need to be mindful that the risks that I'm talking about with those drugs are not my risks. They're the other person's risks. So I'll give them as much objective information as I can, and then the decision is down to them. So there's really, really good evidence now that we need to start treating early. And when I say treating early, it doesn't mean we're not talking the same type of treatment as someone who's had a stroke and needs to go into the hospital within a few hours and start treatment. But we're talking in the bigger scheme of things early. And we know this from lots and lots of reasons. Now, we know from looking at brains, everyone's brain starts to shrink. Our brains are biggest at the age of 20. And from that day on, everyone's brains start to shrink. And someone, a bit depressing, isn't it, that the brain starts to shrink already? So, actually, I see it all the time when someone who's 80 has a CT and an MRI scan, their brain is noticeably smaller. Even if they're that wee sturdy great 80-year-old that's, done really well. And they're that great wee 80-year-old because they've got reserve, and we're going to talk about that. So everyone's brain starts to shrink and get smaller. And we know that people with MS, like if we didn't treat them at all with anything, that their brains are shrinking at a faster rate than someone who doesn't have MS. And the concept of having a neurological reserve, so when someone has a relapse and makes full recovery from that relapse, so if they had weakness in both legs and they made a full recovery, but every time they get a cold or an infection or they're overly tired, their legs feel heavy and they can't walk as far as they normally do, that's because they've lost their reserve. And it's the same with in our brain, with our thinking, and that as time goes on, someone with MS, their brain can shrink over time, and they're getting these little patches of inflammation, so they're losing bits from the inside and they're losing the volume overall. So it's really important that we treat hard. And we know from research that the shrinkage in MS actually starts before we've made a diagnosis in lots of people. So it's happening. We used to think it was something that happened to someone with a progressive form of MS, but we now know that it's happening from the word go. It's happening from the first clinical symptom, and sometimes before the first clinical symptom, the brain has already started to shrink. And we know from looking at studies in people with relapsing and remitting MS who need disease-modifying treatments and are eventually on them, that actually the sooner that process has started, the better outcome overall. So there's 4 clinical trials that have looked at starting disease-modifying treatments in people after the first event, so after a clinically isolated syndrome, and there's categorical evidence in all 4 studies that it delayed the time to their second clinical episode and the diagnosis of MS. We have evidence from the original studies of the beta interferons. So in the people who were started treatment earlier actually survived longer, and that was a surprise to us as MS neurologists, but it was very clear. So in those trials, there was a group of people started on beta interferons and a group of people started on placebo, which had no active treatment in it. And the trial went on for a few years. And after the trial, all the people who were on placebo were offered beta interferon. So we have a group of early starters and a group of late starters. And as a group, the early starters actually survived. So they accrued less disability over time and they survived longer. So early treatment is key. And actually, when we look at how people progress with MS, the actual early part of that process, so the time to the early markers of disability, varies from person to person. But when people with progressive forms of MS meet a certain point in that process, the progression normally follows the same pattern. So it's the early bit that's modifiable. The later bit will happen once they reach that point. So we need to stop people reaching that point. When we look at quality of life, and this is multiple studies in multiple countries, quality of life is significantly reduced in people with very, very mild disability. So this can't be explained by physical disability, but quality of life is significantly impaired. The expanded disability status scale is a disability scale. It's heavily weighted towards actual functioning of arms and particularly legs, but certainly less than 3 is someone whose mobility is unrestricted. They're up and about and walking, and yet their quality of life has already been significantly impacted by this condition. And the same with employment. So people with very mild disability, people whose physical disability can't explain the reason why they're not able to work anymore. So employment falls very early because not related to physical disability. So we need to be aware of that. So in MS, in people who are in employment when they are diagnosed, like 50% are not in employment 10 years later. And it's really, really important. Like employment is really important for people. This is a group of people who are young, they are motivated, they want to be working, and for some reason, as a society, we've got it wrong, or we're not able to accommodate people in the workplace, or their symptoms prevent them from working, but it's really, really important. So when I think about the different delays along the process, because I want people to be diagnosed as early as possible, and I want I want the ones that we need to think about disease-modifying treatments on them early. So I do think people are now presenting to their GP earlier than they used to, I think. And particularly people in the community do seem to be aware of MS as a possibility with symptoms. The time from a GP to a neurologist, well, in different parts of Northern Ireland, it's shocking. It can be 3 years in some parts, the wait to see a neurologist. I don't know what it's like, but 3 years is too long. So then what happens, you get referred to see a neurologist, and that'll be any neurologist, and they might say, you might wait 3 years, or you could wait 18 months. And then you need investigations, and it can take 6 months to get an MRI. I don't think I would like to wait 6 months if I was told you might have MS and we need an MRI. And then the review backlog. So every neurologist in Northern Ireland certainly has a backlog of people waiting to see them for reviews, and then getting these people back with the results of their MRI to say, yes, this is MS. And then like some centres will have an MS specialist clinic and the referral to that. Now certainly in my hospital there wouldn't be a delay between, so if another neurologist referred someone to me and said this person's MS, there isn't a big delay there, but it is still weeks. And I'm sure, again, if you have MS and you've just been told you've MS and you might need treatment, weeks is still a long time. And the waiting time for treatments. And there should be no, I think I went to work in Australia, and it was only when I went to work there that I realised they diagnose MS and they start treatment that day or the next day. There shouldn't be any sort of wait for treatments. There certainly shouldn't be 6-7 month wait for highly active treatments in people with very active disease, but there does seem to be a waiting list at the moment. It's really important that everyone is aware that if somebody has got relapsing remitting MS and is on a disease-modifying treatment and has a clinical relapse, their treatment needs to be escalated, because they don't always come straight to me. They may be seen in the community by a physio or OT. They could be seen in another department in the hospital. They could be admitted as a medical admission, or they could be in the eyes department with an optic neuritis. So everyone needs to know, and this has changed because when I went to medical school, the neurologist didn't need to know after every relapse. But I would want to know, if I have a patient with MS who's on a treatment and they have a new relapse, I want to know that, because not only would I want to think, and lots of people are very good at thinking about treating the relapse and about giving steroids if they need to, and about ongoing care and management for that relapse. But we also have to think of treatment escalation, because if people are having relapses on a treatment, it's not the right treatment for them. And there's lots of evidence now that if someone's on treatment and having a relapse, we should escalate. What we don't know what to do with quite yet is in someone who is on treatment and not having a clinical relapse but has new disease activity in their MRI. So, and with lots of the newer drugs, we're doing MRIs much more often. So we're maybe doing annual MRIs in some people. And it is, of course, very, very reassuring when someone has no lesions. But we don't know, what do we do if someone has 1 or 2 lesions? Certainly it's an easier decision if someone has 5 or 6 or 10 or 12 lesions, and that occasionally happens. But we don't actually know what to do yet with them. But actually, to be able to do all this, again, I need to see people at the right time. I need to see them when if I've said 6 months from their initial assessment or whatever, I need to see them to assess whether the treatment's actually working. And so it's important that we now know that MS is a bit like an iceberg. So the relapses and disability progression is the tip that we can see, but there's lots of things that can happen underneath that we don't see, and that's why it's really important that people are followed up and have MRIs. So what do we know about treatments? We know to treat early. We know that a clinical relapse is escalation of therapy. We know to think of the category 2 drugs on clinical grounds. They're not second line, they are first or second line depending on clinical grounds, and we know to image regularly and to assess regularly. So I would say at least an annual review of clinic, and that's what the NICE guidance said, an annual review. But the annual review that the NICE guidance wants includes weight and smoking and diet and screening for cancer and lots of things that I actually don't necessarily do in my review. So my review isn't enough, even though I do have an annual review happening in my patients. What we don't know about treatments, how to treat MRI activity, we don't know actually how some of these treatments compare to each other. We know lots of the studies have been done in comparison to placebo, and actually placebo-controlled trials really shouldn't exist anymore because we have treatments. It's my opinion they shouldn't exist, that you shouldn't have people with active relapsing remitting MS on placebo in trials anymore. They should be compared to the standard practice. So some of the treatments have been compared to beta interferons, but it depends how the study is set up, whether they've been done in a way that can say whether they're at least as good or whether they are better or not better. So we don't know about some of the comparisons. We don't know the washout. We don't know when we're changing drugs, how long to leave between each drug. And we know in the past that we've been too cautious with that. We know when we were stopping people in the past in natalizumab, and there was a group of people who could have a rebound relapse at 3 or 4 months after treatment, and yet, you know, our practice there was to leave it at least 3 months before we started the new treatment because of the potential risk of other things. But we don't know about switches yet. And what about in people who are doing really, really well? Like I see someone every couple of weeks in clinic who comes in and hasn't had a relapse forever and is on a disease-modifying treatment. Is it safe to stop? Don't actually know the answer to that. Really, really good to know. And pregnancy as well. There's lots of drugs. Not very many drugs are licensed in pregnancy. And yet it's a risky time. Pregnancy itself has a protective effect in relapses, but it takes time for a person to get pregnant. It doesn't happen overnight. In the typical person, the average person takes about 7 months to get pregnant, but that can be 2 years for some people. And that's a long time for someone not to be on treatment. What about in progressive MS? Well, I've said before, people with secondary progressive MS who are still having relapses should be treated with disease-modifying treatments. In primary progressive MS, until very recently, we haven't had any medications that have been beneficial. Now, I think it's been difficult for people who have had progressive forms of MS because there's been so many treatments for relapsing remitting MS. And because there's so many treatments for relapsing remitting MS, and I need to keep a close eye on those people, people with progressive MS may not have got to clinic appointments as quickly. So I think it has been really difficult. There are lots of clinical trials on in progressive MS at the moment, and certainly I would say that there's no doubt anyone as part of the MS community, patient, relative, healthcare professional, everyone at every level does want to see some drugs here for progressive forms of MS, and there is definitely a lot of research happening in this area. The one drug that people are aware of is the ocrelizumab, which has been the first drug to have a positive clinical trial in primary progressive MS. Ocrelizumab, for those of you who haven't heard of it, is one of the humanized monoclonal antibodies. So monoclonal antibodies can come in various forms, and the more humanized they are, the less chances of having an infusion type reaction with them. So ocrelizumab is an antibody to the CD20. So rituximab is actually is a chimeric one, so less humanised. Nocrolizumab is a more humanised version of the rituximab. So, and it had positive effects in relapsing and remitting MS as well. But in the primary progressive study, there was a significant improvement with this. Now, the only thing that is unusual about this group, actually, and lots of people have been aware of it. Is it not on that one? I'm just trying to see what's there. Is the MRI. So it's quite unusual for people with primary progressive MS to have so many gadolinium-enhancing lesions, or patients with gadolinium-enhancing lesions. There was about 25% in each group had gadolinium-enhancing lesions. And that surprised the MS doctors, because it's not what we would have expected to see in a group of people with primary progressive MS. So we've sort of thought, this is obviously brilliant news, that this is a potential drug for primary progressive MS, but that is this saying that we should be looking for gadolinium and active lesions and considering them in a specific population. But there's no doubt that in this study there was a significant reduction in the time for disability progression in the treatment group with ocrelizumab versus placebo. And actually, although this shows the side effects, and there's a list as long as you're on the side effects, you can see that the treatment group and the placebo group are almost identical. So in every study, the placebo group, if the placebo is believable enough, people on placebo will have symptoms. And there was no significant difference between those groups. I just wanted to talk a wee bit about symptom management. There are a lot of symptoms that can be associated with MS, and when someone comes to the clinic, it's really important that we have time and we go through. This is not just about relapses and disease activity and the disease modifying treatment, but all the different types of symptoms that can happen. And I have a clear performer on how to do that and go through everything. My patients know before they come to clinic, I don't know how, they must talk, that I ask everyone about their sexual activity. And so every time I ask it, I get a little giggle. And they go, we knew you were going to ask that. But it's really important to ask these things. You know, we as professionals need to be able to ask the questions that the person themselves might be afraid to mention. And there's sometimes a huge relief when I ask a question. For example, I had a man in recently who had a urethral catheter in. So this catheter was a urethral one, so it goes up through the penis and into the bladder, and it's there all the time. And when I asked him about sexual activity, he said, well, I was sexually active until somebody put the catheter in. So nobody had thought of that in that gentleman. And we need to make sure we're not making assumptions about people. So he was delighted to hear that you could get a suprapubic catheter in. So it's really important that we think of them and that we ask the right questions. It can be really, really complicated to work out what's going on. And I just wanted to talk a bit about fatigue and give an example about how it's really important to really get down into the symptoms and work out what the actual issues are. Because fatigue is a very common symptom in MS. And I would say it's an invisible symptom. It's a very frustrating symptom. I think the number of times somebody says in clinic, if another person tells me how well I'm looking, I'm going to hit them. You know, people get very frustrated. I think it's our natural instinct to be nice to people and tell them all the time that they're looking great, they've lost a bit of weight and their hair looks nice. But that is really very frustrating if you wake up day in, day out and have a symptom like this. And people also feel that they're being judged, that people are looking at them and going, oh, you're off work because of fatigue. And you look, you know, they don't say it, but thought is, well, you look okay to me. And that's the perception from the person who has it, who really wants to go to work, you know, doesn't want to be sitting at home, but is significantly affected by fatigue. So it's a symptom. It can be an MS symptom in itself, but it can be related to so many other things, and they can be interlinked. So it can be a big part of anxiety and depression. It can be secondary to pain, poor sleep. So sleep hygiene is really, really important. So sleep can be interrupted for lots of reasons. Like nocturia would probably be one of the commonest ones, getting up at night to go to the toilet. If you get up 4 times during the night, you're not getting a good quality sleep. But pain or spasms. Fatigue can be a side effect of drugs, so we could be treating somebody's pain with one drug but making their fatigue worse. So it's really important to look at the whole thing together. And it can be something unrelated to MS. You know, we always have to think, you know, this group of people, yes, they have MS, but they're not immune to other things as well. So we have to think of other conditions, you know, anemia, thyroid, diabetes being the commonest other causes of fatigue. And just remembering that fatigue is really, really disabling. And it's really important when someone comes to clinic that they understand, that you understand what fatigue is, that you're empathetic to their fatigue. So this is taken from our NICE guidance. So I would always look for secondary causes. I think when the person and their family can understand that MS, fatigue can be a big part of MS, and what can bring it on, and what can make it worse, and what can make it better. The one treatment that is suggested in the NICE guidance for fatigue is amantadine. Now, we haven't used very much of amantadine in Northern Ireland before it was in the NICE guidance. I've used it a few times. So one of the side effects, a rare side effect of it is a seizure. And I've had 1 or 2 people who've had a seizure, and that is a major effect in people as well. So we really need to be careful that we're using treatments, you know, if they actually need it. The mindfulness, there's good evidence for mindfulness training in fatigue and MS. It's even convinced the MS neurologists. It's in the NICE guidance, and it's there because the evidence is so robust. And neurologists are usually skeptics. So the fact that mindfulness made it there shows you, how sound the evidence is for it. Cognitive behavioural therapy is really good, and I've recently found that there's courses online that people can do. So GP practice in Northern Ireland can refer people for cognitive behavioural therapy, but there's online ones as well. And fatigue management, we would get the advice of OT for fatigue management. I would say there's a bit of a gap there. It can be difficult in some areas to get, if we're allowed to use an OT just purely for fatigue. But, for me it's really, really important. It's a really important symptom, and it's something that we can make a really big effect with. So I do think it is a good use of services. And giving just people advice and education about fatigue. Historically, some people would have had vitamin B12 injections for fatigue, and there's no objective evidence for it unless you've got a vitamin B12 deficiency. So the NICE guidance specifically says do not use it. And I don't suggest it to people with fatigue if they don't have vitamin B12 deficiency, though I do have some people who are still on it. I just put in the MS Essentials documentation, the wee booklet on fatigue. I think it's brilliant, actually. I'm sure there's... Do you have these down here? Yeah. Do you find them useful? I think they're brilliant. I really, really do. Okay. Maybe I'm just going to mention a bit about health promotion because it's really important. Because sometimes I'm in clinic and I'm thinking about all these MS things and I'm keeping their disease activity at bay. I've got them on the best DMT and I'm doing an annual MRI and they're coming to clinic and their bloods are great. But like if they're significantly overweight and about to have a heart attack, that's only one part of them. The person with MS is a person who's got lots of other things going on as well. So it's really important that we look at the whole picture and that people with MS and their families are aware of that. So diet and nutrition is really important, that they have a good, healthy, balanced diet, that they are involved with activity and exercise. And it doesn't always have to be exercise, it can be activity. And smoking. So it's really important that we get the message out there that smoking has a bad effect on MS. So when we look at groups of smokers versus groups of non-smokers, the groups of non-smokers do better than the smoking group. So actually, smoking we know the effects it has on heart disease and cancers and strokes, but it has an effect on MS as well. So it's really important that we as healthcare professionals get that message out. I just wanted to mention this brain health, why time matters in MS. I don't know whether you've seen the documents in this. These really good documents. There's a document for healthcare professionals. There's one for patients. There's really good things there. There's really good things online. I think it's a very, very useful thing. That's the document for the healthcare professionals. And it talks for patients about a brain healthy lifestyle. So, and it's about the cognitive reserve and keeping it there. So it's not just about MS, it's about their general fitness, their general health, their lifestyle choices, smoking and alcohol, about looking at vitamin D and looking at their other risk factors for other conditions and treating them as well. So that's just a summary of that guidance and the pointers to living a brain healthy lifestyle. Okay, I think I'm going to stop before we all fall asleep. I'll maybe open the floor. Anyone have any questions? Yes?
I have two quick questions. The slide you had up with the female to male ratio,
Yes?
steadily increasing over the years, and then at the right hand side of the slide it dipped for a couple of years and then went up again. Any idea what's behind that? And then second question about primary progressive MS, where you have a patient that is showing some evidence of primary inflammation, say get enhancing lesions. You're not allowed to use any of the treatments that are used for relapsing remitting. Is that the case, even though they might be clinically appropriate because they're not indicated for primary progressive MS? Is that right?
You're right. If I say that someone has got primary progressive MS, then I am in no doubt over that. I'm not allowed to use disease-modifying treatments. But if someone has a relapse or they have gadolinium-enhancing lesions on their MRI, and it can happen, I would bring that person back to clinic. I would be going through their history very carefully to make sure that it was a primary progressive MS versus, secondary progressive with relapses. Because when we did the Prevalence study in Northern Ireland in 2003 to 2005, I went out to the northeast in Northern Ireland and visited. I actually went and saw approximately 87% of people in that area with MS, and I took the stories myself, and I examined them myself, and our primary progressive rate was only 7%, and I think it's because I actually physically went and saw them. So in that situation, I would want to go back and say, well, is this definitely primary progressive MS, or could this be secondary progressive with relapses?
Yeah.
And then treat the relapses.
But if there were definitely primary with enhancing lesions, you wouldn't be allowed to treat that. Okay.
No. And
okay.
Yeah, I don't actually know.
Why?
Well spotted, but I don't know why the dip.
Yeah. Okay. Thank you. Thanks for coming.
Oh, no problem. Thank you.
Thank you.
Yeah. There's a question there.
We hear a lot about exercise and physiotherapy, etc. A lot of people tend to drop off when they're developing relapse, and particularly in the acute phase. Would you have a comment to make on that, on whether encouraged to continue or what their exercise status should be?
Their exercise or with physiotherapy. So when someone has a relapse, I would be encouraging them back to exercise when they felt ready. Now after a relapse, there can be a significant fatigue with a relapse, and that can be disabling. And obviously it depends, it's getting the balance right, because you want someone to be returning to exercise or an active lifestyle as soon as possible. But if they have a significant fatigue, you don't want them using all their good energy on an exercise bike or a treadmill, because they have their everyday life to lead. So it's getting the balance right, but I would be encouraging people to get back to an active lifestyle as soon as possible, within reason. And physiotherapy is really useful after a relapse. Steroid treatment. Someone who's got a disability with a relapse, who needs a course of steroids, needs to see a physio as well, most definitely, and needs a course of physiotherapy. But it's educating people with MS that physiotherapy doesn't stop in with the physiotherapist. It's going home and having an exercise program and being motivated to do that. Because I think there's a myth out there that you go and see a physio and whatever they do in that room, that's it. I'm sure if there's physios in the room, they would agree with that. Yeah, it's getting people motivated to do it at home as well.
I'm actually a physio, but I just want to ask about Tysabri. We have a few clients that have been on it for like 2 years, and there's a bit of a kind of, is there something that after the 2 years, or if they're JC positive, and what can they go on to next, and that whole washout period? And I suppose they do question us about it, but we always send them back to talk to their neurologist about it.
So Tysabri is natalizumab. It's one of the category 2 drugs. With Tysabri, it's a drug that works very well with MS. It reduces relapses by at least 2/3, and it reduces new MRI activity by about 80%. So it works really well with MS. There's a risk of an unusual brain condition called PML, so progressive multifocal leukoencephalopathy. And it's a condition caused by a virus that about 50% of us have been exposed to at some point, called the JC virus, and stays latent in your system and can be reactivated. PML is, before these new drugs come out, PML was seen more commonly in people who had HIV or were very immune suppressed in some way. So the risk of PML depends on your JC virus antibody status. So 50% of people will be negative, and they will have a very low risk of PML, though approximately 5 to 10% of them will become positive every year. So you have to recheck those, and the negative JC virus antibody negative ones I would check every 6 months. So the JC virus antibody positive people, their starting risk is about 1 in 1,500 of getting PML. Overall, though we're now able to do an index which tells us how positive they are, and there's a low grip, a middle grip, and a high grip. The high grip are the ones that are the concern. Their risk increases at the 2-year mark significantly, and then it increases after that each year. And we've got data for about 6 or 7 years now. So it's at the 2-year mark that someone who's JC virus antibody positive and has a high index may, when we bring them back to clinic to consent them, they may consider changing. In saying that, I have people who have got a high index and are on this drug and think it's a brilliant drug, have had no relapses, have had no new disease activity, and are staying on it until someone, unless someone tells them otherwise. But other people have been very nervous over the decision. So that's what they're asking you about. But you're doing the right thing by saying, I'm not the right person to answer that question. Absolutely.
Dr. Gray, thank you very much.
Thanks, no problem.